Welcome, everybody. We'll just wait for some people to come in. I set this Zoom up to be sure that everyone was on mute. If you notice that you are not on mute, please put your mute on. Thank you so much for joining us on this beautiful evening. Just going to wait for a couple more people and we'll get started. I also forgot, can everybody hear me? If you can hear me, please give me a thumbs up. I know Dr. Evan can hear me. I want to ensure that everyone else can, just a thumbs up or a wave. Great, thank you for that. Sound is good. I think I will go ahead and get started. Welcome to our lecture series. Thank you for joining us. We appreciate your time and attention. We trust that you will walk away from this lecture with a better understanding of how the shoulder functions and how to prevent injuries of the shoulder. My name is Renee Westmacott. I am the host for the evening. As you may already know, tonight's lecture is the first lecture of Dr. Evan Steinke's three-part upper extremity lecture series. Dr. Evan will start this series with the all-important shoulder. Next up will be the elbow, and then concluding with the wrist. Stay tuned for details of these upcoming topics in our monthly newsletter. Just because you're signed up for this one doesn't mean it'll be the next ones. And so I wanted to clarify that every month it's a new sign up. A little bit about Dr. Evan. Dr. Evan Steinke joined the AST Westman chiropractic team at the beginning of May. Dr. Evan brings a wealth of knowledge to the AST team, and we are thrilled to have him. He has a great understanding of how to connect with patients and put their needs first. You can book with Dr. Evan at AST Westman only. Stay tuned for links on how to book. That will be in the follow-up email, which I'll share more about. Just letting a couple more people in. Little bit of housekeeping. If any questions come up during this lecture, feel free to write them into the chat box. I will be standing by watching for them. If the questions are relevant for the moment, I will interrupt. If not, we can review all of the questions at the end of the lecture. In addition, feel free to stay on the call at the end to ask any further questions. Please join me in welcoming Dr. Evan Steinke to the table. Welcome, Dr. Evan.
Perfect. Thank you. Can you hear me okay?
Yes, we can.
Perfect. So thank you for the introduction, Renee, and welcome everyone. So this is going to be part one of a three-part series, like she was saying. We're going to start with the shoulder today. Next one will be on the elbow, forearm, and lastly, we'll get into wrists and hands after that. So if that is something you're interested in, do make sure you follow up with those newsletters as well. So I did want to mention a little bit about my qualifications to be giving this lecture today. So my school started at U of C here in town. So I went for biomedical science. And I did 3 years there. And on my third year, I actually was starting to get some back pain. And at the time, I was being seen by Dr. Westmacott at Active Sports Therapy. And I realized I really enjoyed the anatomy of it all and wanted to pursue that further. So I ended up going to the University of Western States, where I got my Bachelor's of Science in Human Biology, which is a really great course, lots of anatomy. We did a 9-month cadaver lab and everything. It was really great. And then I stayed at the same school and I got my degree of Doctor of Chiropractic, which is a really great program as well. So I graduated in 2020 and I've been working for about 1.5 years. And just the last couple of months I've been with AST and I've really been loving it. And I'm happy to be putting on this lecture for you guys as well. So a little bit about what we're going to be covering today is just some general anatomy. I'm going to be going over some of the basic muscles and joints and bones that are involved in the shoulder. And then we're going to cover some of the more common injuries that we see walking into our clinic. And then I'm going to cover, what can I do for you in office in terms of treatment and management plans. And then what can you do? So what sort of prevention can you do? What kind of home care? That includes exercises and rehabilitation programs, stretching programs. And then lastly, if we have some time at the end, I'd love to answer any of the questions that you guys have. So here we have some old vintage pictures of the shoulder, and I really just love these because they show just how complex the shoulder joint is. In fact, it's widely regarded as the most complex joint in the human body. So on the one side here, we have all sorts of or all sorts of muscles that are connecting in. And on the other side, we have arteries and venous structures, lymphatic systems. And I just do this to show you that while I will be simplifying things, it really is a complex structure. So just keep in the back of your mind that there are lots of different layers that are going on when a shoulder injury occurs. So in terms of the shoulder, what exactly is it? The shoulder joint, I put in quotes here because it's actually 3 joints. The one that we typically think of as the shoulder joint is known as the GH or glenohumeral joint. And that's this one that I've highlighted with a red circle. So it's a ball and socket joint. It has a lot of mobility. And it really provides us with that great range of motion that we're used to whenever we're picking up stuff or moving objects. That's mostly coming from this joint. The AC or the acromioclavicular joint sits right above it. And this one's not talked about so much, but it is really an interesting joint because if you think about the whole arm and shoulder complex, it's actually completely attached to the skeleton by this joint here. The shoulder blade itself has some muscles that hold it in place, but in terms of bony connections, this is the only one. So it really supports a lot of weight and a lot of forces that go through your shoulder. And then on the other end, we have the SC joint. So this is just the other connection for your collarbone. It tends not to be injured so much, so we don't talk about it a whole lot. If anybody does have questions regarding that, I'd be happy to go into more depth on that. But from here, let's start with the very basic layers. Okay, so the first layer is going to be your bones. And here, I don't want you to worry about any of the names that I'm saying. I'm going to tell you the proper names for them, but really it's just in case your clinician or anybody has mentioned that this is the joint or this is the bone that's affected. Really, I want you to get more of a grasp of what the function of these are. So if we look at the side view, we can see that the shoulder blade is actually a very, very slender bone. Whereas on the front and the back view, it's quite broad. And you can see all these kind of divots and shadows. That's where the muscles are going to attach and provide the shoulder with the range of motion we're used to. This little blue bit that you see, that is the cartilage on top of the bone. So that just provides it with a really smooth surface to glide on. And then the last thing I want to draw your attention to on the bones is on this back image here, you can kind of see a raised bit of bone on the shoulder blade. And that is what we call the spine of the scapula, which will come into play in a little bit here. So if we go to add on the second layer here, we're looking at ligaments. So these are really strong, tough, fibrous connective tissues that basically act to glue the joints together. So if I go kind of back and forth, you can see that it's just right on top of the bony layer. And the main function of this is so that we're not constantly having to use our muscles to hold our joints in place. So these basically act as kind of a fixing agent to keep things more or less in place for when we need them. The other thing I wanted to point out is if you look at the side view, you can see with the humerus removed, with that shoulder joint kind of separated, it's 360 surrounded here. And that produces what we call the joint capsule. So because it's completely surrounded, our body fills that with a fluid so that the joints can move very smoothly and easily across each other. And then another question I get a lot is, what is the difference between a ligament and a tendon? So a ligament is that strong connective tissue that connects bone to bone, whereas a tendon is what connects bone to a muscle. There is one tendon in this image that you can see on the front side. It's kind of just dipping down here in the front. And even in the side, you can kind of see it connecting right up into the top of the shoulder. This is going to come into play when we talk about some of the tendinitises that can happen in the shoulder further on. But let's add the rotator cuff muscles in. So these are a series of 4 muscles that are responsible for a lot of the movement of your shoulder. There are others involved, but these are pretty well-known motion muscles of your shoulder. So they're known by the acronym of SITS, S-I-T-S. And again, don't worry so much about the name. However, in this time, I'm going to kind of explain the names because they tell us exactly where the muscles are and what their function is a bit. So supra means above, and spinatus is referring to spine. So before I kind of mentioned that's the spine of the scapula. So that just means it sits right above the spine of the scapula here. And its main function is to basically raise your shoulder up from a resting position. Infraspinatus just means below the spine, so it sits right here. And just below that is your teres minor. And this muscle is teres, meaning round and long, almost works exactly the same as the infraspinatus. So we really think of them as having the same function. And then the last of them is called subscapularis. Now, sub means below, and scapularis means shoulder blade. So this basically sits underneath. It's kind of sandwiched between the shoulder blade itself and your rib cage. And that makes it pretty difficult to get to when we're trying to treat it. So if anybody here has been treated by me before, you know that we tend to have to raise the arm up and kind of go in through the underarm there to really target this muscle. And it tends to be quite tight, but it's a really important muscle. So we'll be touching on it a bit later as well. And then even though it's not a rotator cuff, the bicep muscle is pretty important. And you can see that over here. So this is the one that was the tendon on the previous one. And we'll be talking a bit about those injuries as well. The very last layer that I want to discuss is the nerves. We'll be touching more on these in the elbow and the wrist lectures, but really they're starting from your neck. So don't be surprised if you're having shoulder pain that's accompanied by neck pain, or if your clinician wants to check your neck as well, because at each level of your spine, you're having nerves come out. And they kind of rejoin in what we call a plexus, like a network of nerves. And they kind of rejoin and spread out and rejoin, and they form all of these nerves that are going to be passing down your arm. And on the right image, you can see that they're just passing through so many muscles and past so many joints. There's a lot of areas for them to get pinched or compressed, and that can cause symptoms down your arm. Symptoms that would look like numbness, tingling, weakness into the arm. That can usually stem from nerve injuries. And likewise, anything that is getting compressed further down can also cause that. So again, in the elbow lectures, we'll be talking about getting nerves being compressed around the elbow region. So that's enough anatomy for now. So I think we can get into some of the more common injuries. In fact, the collarbone, as we were discussing before, is the only bony connection from your whole shoulder complex into your skeleton. So it has to provide a lot of strength and resist a lot of forces that are getting pushed through there. So it's this bone right here. And it's actually the most fractured bone in the human body, accounting for about 2.5% of all fractures. And in terms of treatment, if we suspect a fracture there, typically we're going to order an X-ray because there's really 2 results that can happen. If the broken parts are approximate to each other, then we're looking at sling and giving you rest, because the body will be able to heal itself. This isn't always what people want to hear because they want a quick fix, but it really tends to happen that way. On the off chance that the broken parts are too far away from each other on the X-ray, they might wait and see to see if they get a bit closer, or if it's broken in multiple spots, they're probably going to recommend you as a candidate for surgery, at which point they're probably going to put a plate and some screws and just connect it themselves. So if we move away from bones and we head over to joints here, The shoulder joint itself, again, being a ball and socket joint, provides a huge amount of mobility. However, that's also kind of its downside. Because the glenohumeral joint is the most mobile in the human body, it's also the most dislocated as well. So there's a good chance that somebody here even had a dislocation of their shoulder before. And unfortunately, once that happens, it tends to stretch that capsule that we were talking about, those ligaments, making you more prone to getting it in the future. So in terms of treating this, there's again kind of two options. The first is, if there's no major symptoms besides the discomfort of it being dislocated and the lack of movement, you want to get it urgently relocated. So going to an urgent care or finding somebody that's had this before, and getting it relocated properly is key. On the off chance, this is more rare, but if you're getting circulation or nerve issues, this is when we want to consider immediately relocating it. So again, that would be something like you're getting a pinch in the shoulder and your fingers are starting to go white because there's loss of circulation. Maybe you're getting the numbness, the tingling, the weakness down the arm. That might mean the nerve's getting pressed. In that case, you're really looking at getting it relocated as soon as possible. So, finding the nearest qualified person is really quite urgent in that case. And now for kind of the bread and butter of shoulder injuries, it's the rotator cuffs, okay? So a study looked at about 1,400 shoulders, and they found over 20% had a full rotator cuff tear. So, in another study I looked at was around 22%. So you're looking at maybe 1 in 4 to 1 in 5 people in a general population that have a complete tear in one of these muscles. Rotator cuff tears are the most common cause of shoulder problems in patients when they come in, and about 35% of tears are symptomatic, which is actually kind of surprising. You're looking at about 2/3 of people that are walking around with a rotator cuff tear and they don't even know. And then lastly, of those 4 muscles, the supraspinatus, which is the one pictured in this image, that is by far the most commonly torn of those 4 muscles as well. So if we dive into the prevalence a little bit more, and if we look at this graph here, you can see that really in the 20s to 40s, it's not very common. It's not to say it doesn't happen, but in this age range, you're really more looking at like a sports injury, a trauma, maybe it was a motor vehicle accident. That's the sort of injury that would kind of cause a rotator cuff tear in this age range. But for the most part, they're really overuse injuries, and which is why we see them more in the 50s to 80s age range. But if we break that down a little bit further and we go by male and females, here we can see that in the 50s, it's almost only males that get the tears. However, by the time people are in their 80s, it's actually more likely to be female. Now, the authors tried to account for this, and it mostly came down to the occupation, with males tending to have more physical jobs that were increasing their risk of injuring their rotator cuffs. But even more interesting than that is, again, if we go back to the symptomatic or asymptomatic side of things, in their 50s, it's almost 50-50. If you have a full tear, about half of them will have symptoms with it. At the time we're in our 80s, roughly 36% of people are having tears, and only around 11% are even feeling any of the symptoms involved. So what are some of the key risk factors that are making rotator cuff tears so prevalent? One is occupation. So they found that having a job where you're really using your shoulder a lot, so jobs in agriculture were really prominent for this. Stuff like being a lumberjack was really high up there. Other categories would be stuff like overuse or microtraumas. And for this, you could think of like a cashier, for instance. Typically, they stand in one position all day and they're scanning in one direction. It's a very overuse of their shoulder, right? And companies are starting to realize this. They're trying to make the checkouts face different directions so that they can scan one way, switch to a different stall and scan the other way. But these are the sort of overuse traumas that can increase that. Metabolic disorders can increase that. So that would be anything from diabetes, like hypertension can cause that. I'm blanking on that one. High cholesterol can also cause, an increased risk as well. Cigarette smoking is also known, just in general, it can decrease healing times in your body. So that's definitely a contributor. And then unfortunately, some people just have a genetic predisposition to having these as well. So what can we do as chiropractors to help you with a rotator cuff tear? Well, the first step is always an evaluation. I need to check exactly which of those muscles is being affected, which joints are being involved. And if I really know for sure it's a rotator cuff, I don't actually have to take any imaging. We can just start treatment. But on the chance where there's something else I need to rule out, something a little more concerning, we'll probably do an X-ray and an ultrasound. Now, X-rays only show bones, but really what we're looking for here is to see, is the bone aligned correctly with the shoulder joint? And is there any damage to it? Maybe you have a really hard fall. Sometimes the bones can actually collide and get little chips in them. So that might be something that would pick up on an X-ray. The ultrasound, on the other hand, that's going to be looking at muscles. So that can tell me which muscles are torn. And not only that, it can tell me how torn are they? Is it a little partial tear? Is it a complete tear? And if it's a complete tear, how far apart, how separated are the two ends? Sometimes if they're close enough, it can actually reconnect and heal. But if they're pulled quite far apart, then there's quite a low chance of those reconnecting. And once we get that information, we can dive right into treatment, which I've split into two phases here. For any acute injury that's really happened in the last few days, last week or so, the goal tends to be to just reduce the inflammation that you're feeling. So inflammation is that kind of swelling, irritated feeling, and it would really make it more difficult to assess because almost any motion of your shoulder is going to be painful on this stage. So our goal is to reduce that. So you can take things like NSAIDs, which are, that stands for non-steroidal anti-inflammatory drugs. So this would be your ibuprofens, your Advils, your Motrins, that sort of stuff, just over the counter. And ice can also help reduce some of that swelling, which will also be a bit of a pain reliever as well. And then we would consider something like a work and sports restriction. At work, maybe you're a warehouse worker and you're lifting lots of boxes. Maybe you have to go on modified duties for a while, let that relax a bit and cool off so that we can work on it more. We don't want to aggravate it any more than it already is after a fresh tear. And then sports restrictions. Maybe you can only do light practice for a few weeks in no contact sports, that sort of thing. So it really depends on what you are, doing for work or sports and how you receive the injury as well. Phase 2 is really starting as soon as phase 1 is over or almost over. And that's when we do muscle work. Not only muscle work on the one that's torn, because especially in a full tear where it's separated, you're no longer getting the strength of that muscle. So when you try to activate it, it's really not going to provide any motion to your joint. So we're also working on the surrounding muscles to build their strength and to help them basically pick up the slack of the injured muscle. And again, if you go back to that first shoulder image I showed you, there are so many muscles in the shoulder that we can basically utilize to pick up on whichever muscle is injured. And then we can do stuff like modalities. So laser, ultrasound, IFC stands for interferential current. It's kind of the one where you stick those pads and pass electricity through the muscle. These can all help reduce pain. We can help improve the healing time of injuries as well. And then at this point, we would be considering activity modifications. So maybe you are in a sport and you just want to modify the way that you're doing it. Maybe you're having a hard time getting out of bed and we can help you find a certain maneuver or mechanism that will help you get up without pain. And then the really, really big one is rehabilitation. So that one kind of falls into home care. So I'll touch on that a bit later. but we kind of break that one down into its own set of phases as well. So in terms of prevention, what can you do to prevent? One of the things we're always worried about is something called frozen shoulder. The link is here because I just wrote a blog post earlier this month on that. But I'll give you a summary. Frozen shoulder is when the joint capsule, which you can see in the picture is the red part, it basically freezes. It starts to reduce its mobility. It starts to tighten up and constrict, which can cause significant pain. Now, the reason we want to prevent frozen shoulder so much is because it takes about 1.5 to 2.5 years to resolve. It's really quite a time-consuming diagnosis if you were to get it. So we're always thinking, how can we reduce the risk of getting frozen shoulder? And the key there is some of the mobility and stretches that we'll go over, but it's also reducing the risk factors of getting it in the first place. So some of the risk factors are things like occupation. So depending on what your occupation is, maybe you're an office worker, what are the ergonomics like? What's your setup like? Are your monitors raised to the correct height? Do you have armrests so you don't have to hike your shoulder? Do you need a board in front of your keyboard to rest your wrists on? All sorts of things that just will reduce your risk of having a shoulder injury at work. And then there's always the occupations that are more prone to it, like lumberjacks or store clerks, that sort of stuff. How can we switch hands while you're doing certain tasks? And then posture is a big one, right? Are we sitting up straight enough? Are our shoulders always rolled forward? Can we pull them back a bit more often? And then biomechanics, if you're lifting things frequently, are we doing it kind of outstretched and too far in front of us? Can we bring it in closer and use our hips and our core to lift rather than our shoulders? And similarly, like sporting injuries are a really common way to do this. So, warm-ups, are you targeting the right muscle? Are you stretching the proper amount of time? And are you wearing the correct protective gear in terms of, especially for contact sports, right? And then the other thing you would want to do is teach people how to fall. It might sound silly. When we're surprised and we fall, we tend to lock out our shoulders and our elbows, and we fall. And this is pretty well a built-in instinct when we fall, but in sports, sometimes you can see it coming. You're about to get tackled. That you're starting to slip and you're going to fall. So how can you position your body a little bit better so that you're not sending all that force through the shoulder joint? And again, with those like locked out arms, that you're risking the dislocation, the fracture again, right? So teaching people how to fall can be quite beneficial. And then there's always the general health, right? Diet and exercise are really important. Are you staying hydrated? Are you eating enough, leafy greens and getting enough calcium in your diet to have strong bones? And similarly with exercise, if you're only doing cardio, you might be missing out on some of the benefits of, even lightweight training can help build bone strength. And then of course, smoking cessation. Best bet there, if you want to quit smoking, is probably to go through your MD. They have lots of great programs that they have access to that they can send you for that can help you quit smoking, because it's a difficult one, but it really does make a difference in preventing not only shoulder injuries, really just improving your general health. So let's go into a little bit more about home care. So here I just picked some basic stretches. Now these are preventative, and the first two can also be kind of at the start of a rehab stage. For the cross chest stretch, basically what I want you to do is you would relax your shoulder on the affected arm, and you're just going to swing across enough. Now, it doesn't have to be quite at shoulder height. I find if you bring it down a little bit and pull in really good, you want to use the other arm to do the pulling and really relax this arm. This stretches right into the back of that shoulder blade, into those affected rotator cuffs. So that's a great way to start. The doorway stretch, on the other hand, is what's going to get you through the front. Okay, so if you raise your arms on your elbows and you walk through a doorway, just kind of let your elbows catch on the door frame, and then you're just going to gently push your chest through until you feel a nice stretch through the front of the pecs. And some of the rotator cuffs as well as it gets pulled through. You can do this one way, or you can use both at the same time, really up to you. And I'd always recommend to try to do this when your muscles are nice and warm. So especially in Canada, when you're cold from a winter's day, don't try to stretch your muscles. Try to do it after like a nice warm shower or after a workout. That's always a great time too. And then the third one is arm circles. Now, the reason this one is more of a preventative one is because if you do have a shoulder injury, you'll probably find it hard to get your shoulders to 90 degrees or maybe even above shoulder height. But this one's just a nice, easy way to keep that mobility and motion going in there. Again, I'm thinking about, how can we prevent something like frozen shoulder? Key is always mobility. And if the T-pose is really easy for you, you can always go overhead and do some arm circles up there. You can even just do shoulder shrugs if you want to just get the shoulders involved. All good ways to stretch at home. In terms of exercises, I kind of split them into 3 groups here. So the first one is pendulum swing. Now, we usually give this to somebody that just hurt their shoulder, like a fresh injured shoulder. You don't want to be contracting the muscles that are involved because they're just so painful at this time. So the trick is, how do we get mobility and move that shoulder without actually contracting it? So what we do is we get into this basically a tripod stance. So both legs down and one arm supported on a table, and the affected arm just drops by gravity. And basically you move your legs and your chest and everything except the arm, and you sway your body back and forth, and that lets your arm just kind of drift. And it gets the mobility in there without ever having to contract that set of muscles. So this is a really great one for people that have just injured themselves. The next step up would be isometrics. So here it's a similar idea. Now we're contracting the muscle, but we're not changing the length. So you can imagine if you go up to a wall or a door and you go to rotate your arm out and it's just pressing up against the wall, right? The wall's not going anywhere, your arm's not going anywhere, but you're still sending the signals and you can still feel the contraction in your arm. You can think about this in a way of like, if you just had a cast on both arms and you took the cast off of your right arm and you see that it's looking a little bit slender, it's not quite as full as your left arm. That's because when it was in the cast, you really weren't using it much, and the muscle tends to deteriorate a little bit. We call it atrophy. So by doing these isometrics, we're not having to move the muscle a whole lot, but we're still stimulating it. The nerves are still firing it, and that encourages it to maintain itself. So again, this is like the very basics of when we start having these injuries. That's where we want to go next. From there, we'll look at resistance bands. So similar to the isometrics, but now we're actually changing the length. So you can tie these off on doorknobs, and they come in all sorts of different resistances, right? So you have light, medium, heavy, and depending on where you are and what stage, you'll probably start at a light to a medium and work your way up. Here they show kind of the external rotation in the first image and that internal towards your stomach in the second one. These are great motions that cover almost all of the rotator cuffs. Depending on, again, on which muscles are hurt, we might modify this for you, but almost every program is going to have these two in it. And then following that, you're looking at, how can I build the strength of these muscles? So this is kind of near the end when things are mostly resolved. We're trying to increase the strength of either the injured muscle or the surrounding ones. So in this case, he's doing, tricep extensions, but this might as easily be, bicep curls or, rows, anything like that. You're just trying to build that shoulder strength in general. So let's get into bicep tendonitis. So the biceps are shown here and here. These are the two heads of it. And you can see that they're actually really close to like a supraspinatus tear. So whenever a rotator cuff is torn, we tend to check this muscle just because by proximity, it usually gets affected. You'll typically feel pain more in the front of the shoulder because that's where it is. And sometimes these tendons can snap and pop as you begin to lift and raise your shoulder. The evaluation for this is basically we check the strength of the muscle. Is it still flexible enough? Is there enough strength in it? How is your shoulder moving? Maybe sometimes we can even hear or feel the pop of the tendons as you try to move your shoulder. So that gives us an indication. And this can also kind of swell up and cause joint pain as well, because that short head of the bicep really, it wraps right into that shoulder joint itself. So again, one that we look at pretty closely to make sure that this, to determine if this is or is not involved in your shoulder injury. Again, this will probably end up in an X-ray or an ultrasound if it's accompanied with a tendon tear. The ultrasound will actually pick up tendonitis. So if there's enough of a change in the cell structure, the ultrasound tech can actually see that, and they will report bicep tendonitis, which gives us a better idea of where and how to treat it. Again, in the first stages, it's really to reduce that inflammation again. So rest, the Advil or Motrin, ibuprofen, ice, that sort of stuff to start. In this case, if there's no tear, we might actually adjust the joints themselves, depending on what the mobility of that shoulder is. We typically will do kind of like an inferior pushing down on the shoulder adjustment, and then we'll do muscle release techniques. So that could be anything from active release therapy to cross friction massages, or we might choose a modality like a IFC or a laser, even ultrasound, to help improve the healing times of the tendonitis. And then lastly, I wanted to touch on impingement. So shoulder impingement is pretty common to accompany some of these previous ones. Now, impingement is when you try to raise your shoulder and it basically pinches. You can see where that red lightning bolt is. That's basically where the pain would kind of emanate from. And as you raise your shoulder, if it's not quite in the center of the joint, as it lifts up, it basically pinches the other structures, the muscle, and in this case, that blue blob called the bursa there, pinches it between the two bony parts. And you'll get what we call a painful arc. So kind of between 60 and 120 degrees, you're feeling quite painful. Sometimes once you get past 120, the pain actually completely disappears. If it's bad enough, sometimes you can only get to 90 degrees and it feels like it's physically stuck. You just can't raise it anymore. In that case, we'll typically do something like an adjustment. We're trying to pull the humeral head lower so that it's not crushing all of those structures above. Again, you want to reduce that inflammation, because the more things are swollen, the less room there are for things to move. That would include changing ergonomics, biomechanics, and even changing your sleeping position. If you tend to sleep on your side, we'd recommend that you sleep on the other side, or on your back would be even better, just so that there's not a whole lot of pressure going through here, because we want it to heal as quick as possible. And then going back to that subscapularis, this is that one that's kind of sandwiched between your ribcage and your shoulder blade. We want to strengthen that because it pulls down on the shoulder as you begin to raise it, and it gives more space. So there's less of a chance of impingement, which is similar to what we're trying to do with the adjustment. We're just trying to bring everything a little bit lower so there's more space. And that pretty much covers the most common shoulder injuries that we see walk through our doors. I'd love to open up to any questions, and big thanks to Active Sports Therapy for letting me host this lecture. I hope everybody learned something that's helpful for them.
Wonderful. Thank you for all that information. I certainly learned a lot about the shoulder, and your explanation was very clear and informative. So one question did come up.
Sure.
I believe I know the answer, but I don't want to assume. In the event that you have a dislocated shoulder, do you go to a physio, or is it more like urgent care emergency room setting?
Yeah, so if it's your first time, especially, you want to more go to like an urgent care. In general, I would say urgent care. If it's something that's happened frequently enough, like the people that get it, again, it increases the chance of you getting it again. they after the second or third time, they're pretty much taught how to do it themselves so that they can relocate it. But definitely go to an urgent care setting the first time around. Yeah.
Okay, from my understanding, it could be very painful. So for the first or
Yes.
second time, it certainly needs maybe some medication to numb the pain while they put it back in.
Yeah.
So actually, I worded that wrong too. So what professionals are qualified in the event it's the fifth shoulder dislocation? Would somebody want to maybe come to the chiropractor or physio? Is that something that you can help with?
Yeah, so it depends. Some chiros are qualified, not all are. And physiotherapists, I believe, are qualified. MDs are definitely, and I believe a lot of nurses are actually trained as well to relocate them.
Okay, perfect. Thank you. Are there any further questions? In case any are coming in, I want to point out that Dr. Steinke put together the link to our website. You'll be able to find him at Westman Village, practicing out of Westman Village, not Willow Park. He did a wonderful blog, if you haven't read it, on frozen shoulder, and there are 2 more blogs coming up. So do check out the AST website on a regular basis to see what blogs are coming up. There's one, I think, Dr. Steinke, we have one for July as well as August.
Yeah.
And those are coming down the line. A couple more questions did come in. I'll read it as it was written. Are shoulders a specialty for Dr. Evan?
Yeah, I like to work on shoulders a lot. In fact, all upper extremities, which is partly why I picked this this lecture series. Yeah, I spent a lot of time doing shoulders in my during my degree, and my clinician helped me a lot with doing some of the adjustments for those, as well as some of the muscle work. So yeah, I definitely do focus on upper extremities in general.
Okay, fantastic. I'll just put it out there in case there's any more questions. Feel free to speak up. In the meantime, do check out, sorry, my dog is joining us. Do check out our monthly newsletter, which comes out on the first Friday of every month, where you can sign up for future lectures, learn about the blogs that we have up that we featured for the month. And I think that is all. I'm not seeing any more questions. Thank you so much for the information, Dr. Evan. Be sure to call AST Westman to book an appointment with Dr. Evan soon. If you're an existing patient, you can book online for Westman Village as well. I think that is all for now. Thank you so much for joining us. And one more thank you, Dr. Evan, for the wonderful lecture you put together.
Thank you so much.
Okay, have a great night, everybody. Bye for now.